So good morning, and I'd like to start by thanking the organiser of Myeloma Ireland for inviting me to provide an overview of multiple myeloma today. My name is Niamh Keane, and I'm a consultant haematologist based out of Galway University Hospital. I have a special interest in multiple myeloma. So just to give you a quick outline of the talk today, so first I'm going to discuss the biology of myeloma and the immunoglobulin protein. That's a very important part of diagnosis and monitoring of the disease and what that means. I'll also talk about how we actually diagnose multiple myeloma and its related and precursor conditions, the clinical features of myeloma and how they affect patients, and I'll give a broad overview of the management of multiple myeloma also. So to begin with, I'll just describe for you the normal bone marrow. So if you see the diagram on the left here, you see a slice through a normal piece of bone. And basically on the outside, you have this hard cortex area, and on the inside, you have a softer, spongy area, which is full of tiny cavities. It's within these cavities that our normal blood cells are all made. And all of these originate from what we call a hematopoietic stem cell. And that is pictured here. So these hematopoietic stem cells give rise to each of the red blood cells, which give us our hemoglobin, the oxygen-carrying molecule that brings oxygen all around our bodies and allows us to have energy. White blood cells, which allow us to fight infection, and these include a different range of cells, including neutrophils, which fight bacterial infections, and lymphocytes, which also have a very important role in the immune system and in remembering immunity. And also platelets, which are tiny fragments circulating in the blood that prevent bruising and bleeding. So this is how our bone marrow normally functions. In multiple myeloma, one of the types of white blood cells has become abnormal. It's acquired an abnormality and it's gone rogue in essence and taken over the bone marrow. So in the normal course of things, we have these white blood cells called lymphocytes, and we see here a B lymphocyte. So all through your life, your lymphocytes are encountering different infections, and different proteins contained on these infections are called antigens. The white blood cells, or the B lymphocytes, learn to recognize these antigens and produce what we call an antibody. And another name for an antibody is an immunoglobulin. These antibodies can encounter the infection, they can bind to it, and they can target it for killing. And when the lymphocyte goes on to become more of a permanent cell that's going to reside in the bone marrow and remember that particular infection and make that antibody, we call it a plasma cell. And it looks something like this, with a powerhouse nucleus here that is contained at the side of the cell. In the normal course of things, you have lots of different plasma cells that remember lots of different infections that you would have encountered throughout your life, and they produce lots of different antibodies. However, in multiple myeloma, some change has happened in one of the particular plasma cells. We call this a genetic change or damage to the genetic content or DNA of the cell. This doesn't mean that it's hereditary. It's actually an acquired abnormality that you weren't born with, you don't inherit, and you don't pass it on to your children. So unfortunately, a change happens in one of these cells which allows it to flourish and divide and take over the bone marrow. And we see little clusters of these plasma cells throughout the bone marrow in patients with multiple myeloma. And this is in fact where the multiple part of the name comes from. One particular cell that would have originally encountered one particular antigen goes rogue in multiple myeloma and it starts to take over. So instead of lots of nice normal antibodies, you have lots of one particular type of antibodies. And this results in loss of the memory of other infections that you would have encountered throughout your life. So this is what the plasma cells look like in multiple myeloma. As you can see here, we still have the nucleus that would be present in all cells. And we have the cytoplasm, which is kind of another part of the cell here. This very large white area here is where all these antibodies or immunoglobulins are made, and the red arrows point these out. On the other side here, you can see other little pockets of immunoglobulin pointed out by the black arrows. So myeloma cells are a bit unusual for a cancer in that they continue to do their day job even after they've become malignant. And for this reason, an abundance of these proteins or antibodies is made, and this helps us in the diagnosis of myeloma and in monitoring the treatment of myeloma. So when we talk about antibodies or immunoglobulins, what we're talking about really is the final product of the B cell immunity. And this is in essence what an immunoglobulin molecule looks like. It's made up of two different components called a heavy chain, and there are two of them here that are joined together by a bridge, and also a light chain. So if you have multiple myeloma, you may have heard us referring to light chains as well as to the immunoglobulin protein. And this is because in most forms of multiple myeloma, the intact immunoglobulin complete with both heavy chains and light chains joined together is secreted. But in particular myelomas, only the light chain component is made. And this is what we call a light chain myeloma. We monitor these slightly differently. So there are many changes that occur in the proteins in the body in multiple myeloma. As I said, we normally have a broad range of immunoglobulins or antibodies, and this is what we call polyclonal immunity. And this is, in essence, means that every infection that you've ever encountered is represented in one of the immunoglobulins or antibodies that is produced. In multiple myeloma, we lose these because this one monoclonal antibody takes over. And we have many different names, which can be a little bit confusing for this antibody. Sometimes it's called an M-spike or a paraprotein or a monoclonal band, but they all mean the same thing. They mean that one particular antibody or immunoglobulin that your multiple myeloma is making. And the loss of the normal antibodies that would normally be present is the reason why multiple myeloma patients are at risk for infections. So here we have a representation of kind of the normal antibody repertoire that you would have. So each of these different colored antibodies would represent one infection that you encountered throughout your life. In multiple myeloma, one of these antibodies comes to dominate, and that's the only one that is now produced. So over the normal course of things in health, if we were to run serum of your your serum across a gel, we see a smear like this, where we see all of the different antibodies that you would have eventually or originally encountered throughout your life. In multiple myeloma, one particular antibody is taken over, and we see one M-spike here on the gel. And that's what we're referring to when we talk about the M-spike or the paraprotein. The serum-free light chains can also be measured in the laboratory. And when we do this, so here I turned the structure of the antibody on its side, and we're measuring the hidden surface of the light chains. And this will tell us how much of the patient's protein is made up of intact immunoglobulin and how much of it is made of light chains. So for a patient with light chain multiple myeloma, we'll be very interested in measuring these free light chains, and these in particular can cause kidney damage. For some patients, they won't make the intact immunoglobulin protein at all, and the only thing that we have to monitor is the serum-free light chain. This also becomes important diagnostically because we make two different light chains in health, a kappa light chain and a lambda light chain, and the ratio between these two can be important diagnostically, and I'll come back to that. So essentially there is a spectrum of plasma cell disorders that patients can have. Over here on the left we see a normal plasma cell in health. Somewhere along the way, this can acquire a genetic change, and as I say, this is not a hereditary change, this is an acquired change to the cell, which switches it on and means that that one cell becomes very active and produces that one M-spike or monoclonal paraprotein. When this happens, we have a condition called MGUS or monoclonal gammopathy of unknown significance. And for all of the different plasma cell disorders, there generally is a monoclonal protein present, be it an intact immunoglobulin or a light chain. When there's a little bit more burden of plasma cells in the bone marrow, so greater than 10%, we come to refer to this as a smouldering myeloma, and I'll talk more about this in a moment. When we see evidence that the plasma cells and that the paraprotein are causing damage to the patient's organs, we say that they have active multiple myeloma, and we refer to the CRAB criteria for this, that is hypercalcemia or high calcium in the blood, renal damage or kidney damage, anemia where your red blood cells are low, or bone damage. And much later in the course of disease, the plasma cells can actually become independent of the bone marrow and travel outside of it, and we call that extramedullary disease. So this initial change in the genetic structure of the plasma cells is seen from the beginning, from the earliest stage of MGUS right through. And what we have come to understand makes a change and causes patients to develop either smouldering myeloma or active myeloma is where there are additional genetic changes, again, not hereditary changes, but acquired changes throughout your life that cause the multiple myeloma to develop, or where the immune system of the patient is no longer capable of holding the malignant plasma cells in check. And we're beginning to understand this more and more. So what tests do we use in the diagnosis of multiple myeloma? Well, we can look at both the blood and the urine to measure this M-spike or paraprotein and to measure the light chains. We also tend to perform a bone marrow biopsy, And we're doing this specifically to look for the percentage of plasma cells that are present. So what percentage of the bone marrow has been taken over by these malignant plasma cells, and also to look at the genetics of the myeloma, which is not the same as looking at the patient's genetics. It's looking at these acquired abnormalities. And the genetics can be very useful in determining how patients are going to do long term and how they may respond to certain treatments. Other blood tests are used to look for anemia, for kidney damage, and for evidence that your calcium is high, and this is very important diagnostically. We also do bony imaging to look for damage in the bones, and I'll talk more about the bone effects in multiple myeloma in a moment. We used to do plain film x-rays to look at all of the different bones and try and look for punched out lesions affected by plasma cells. But we've now moved to performing more sophisticated imaging, including CT skeletal survey, or sometimes an MRI or a PET scan. So the first category of plasma cell disorder is this monoclonal gammopathy of undetermined significance. We diagnose this when your GP or whatever doctor is looking after you detects one of these monoclonal proteins in your blood. In MGUS, it's less than 30 grams per litre, and we have a very low burden of plasma cells in the bone marrow, so less than 10%. The important part with MGUS also is that there is no symptoms of disease. So there is no evidence of high calcium, of kidney problems, of anemia, or of bone disease. We do not regard this as a cancer, and we know that it increases in frequency with age. Many different groups have studied the prevalence, or how much MGUS is out there in a given population, and we know that by age 50, 1 to 2% of us will have a detective monoclonal paraprotein that will fall into the MGUS category. By the age of 70, it's approximately 3%, and over the age of 80, 5 to 10% of people will have one of these proteins detectable. So it becomes very common with age. Smouldering or asymptomatic multiple myeloma then is the next category. So the diagnostic criteria for this are very similar to MGUS, except that they tend to have a higher monoclonal paraprotein, so it's greater than 30 usually, and or a higher burden of plasma cells in the bone marrow, so generally greater than 10%. But importantly, there's no evidence of multiple myeloma CRAB features, so the high calcium, kidney damage, anemia, or bony problems. So it is regarded as a cancer, but not requiring treatment. So why do we care about these precursor conditions if patients don't require treatment? Well, it's because there is the potential for them to develop into multiple myeloma, and we need to monitor patients appropriately. So some of you may have been originally diagnosed with MGUS or with a smouldering myeloma and then went on to develop symptomatic multiple myeloma requiring treatment. If you're initially in the MGUS category, your risk is 1% per year. So for example, of 100 people diagnosed with MGUS at 5 years, 5% will have gone on to develop multiple myeloma. At 10 years, 10% will have gone on to develop multiple myeloma. And over time, we can determine the risk for an individual depending on the rate of change or the type of MGUS that they have. Within the smouldering category, the risk of development of multiple myeloma annually is much greater. For the first 5 years, 10% of patients in this category will go on to develop multiple myeloma. Thereafter, it drops to 3%. And after 10 years, it's parallel with MGUS, so 1% per year. So basically, a patient who has had a diagnosis of multiple or smouldering myeloma who has not progressed within 10 years essentially has the same risk as an MGUS patient. And this group of patients here at the start of the curve was of great interest because these patients were at very high risk of progression to multiple myeloma. You can see that this is very steep, so very many patients here progressing rapidly to multiple myeloma. And observation of this caused a change in the diagnostic criteria for multiple myeloma. So basically, we now know that patients who otherwise would have been given a diagnosis of smouldering myeloma, but who have a very high level of plasma cells in the bone marrow, so where it exceeds 60%, these patients will go on to develop the symptoms and the signs of multiple myeloma within 2 years. And we now regard these patients as deserving of treatment for multiple myeloma. So on these graphs, each drop down on the curve from 100 is a patient going on to develop multiple myeloma. And you can see here on the green curve that patients with greater than 60% bone marrow plasma cells within 2 years, basically all of them had gone on to require treatment for multiple myeloma. Similarly here with the free light chain. So remember I mentioned that there are two different types of light chains, there's a kappa and a lambda. But depending on which one is involved, the ratio is calculated. So you divide, for example, the kappa light chain by the lambda light chain. If the ratio is greater than 100, we now know that these patients are very high risk for developing symptomatic multiple myeloma. And similarly, patients with more than one focal bone lesion on the new sophisticated imaging that we do, we know that these patients are likely to run into trouble and require treatment for multiple myeloma within 2 years. So these now form new diagnostic criteria. So while I say that the CRAB criteria are required for diagnosis of multiple myeloma, if you're watching this morning and you're on treatment without having had the CRAB features, it will be because either you had a light chain ratio that exceeded 100, you had more than one bone lesion on your imaging, or in your bone marrow biopsy, there was greater than 60% involvement with plasma cells. And we know that these patients are going to require treatment inevitably within 2 years, and we know that people do better if they're treated earlier. So these are the new criteria for multiple myeloma then. So you have to detect a monoclonal plasma cell in the bone marrow, and it has to be greater than 10%, or a biopsy-proven plasmacytoma, which is a little pocket of plasma cells outside of the bone or within the bone marrow. A monoclonal protein present in the serum and or urine, and symptoms of the CRAB criteria or one of these newer criteria that I've described. So this is a cancer and it does require treatment. So the clinical manifestations of multiple myeloma. So the most common clinical manifestation is bone disease. And basically what's happening is the plasma cells have taken over an area of the bone and they've caused loss of the integrity of the bone and the structure of the bone. You can see the classic lesions that we typically see in the skulls here, where there's a punched out lytic lesion from the plasma cells taking over that piece of the bone. Similarly, here in the long bones, you can also have a large lytic lesion, and this will be very high risk for fracture. Very commonly, the vertebra or the bones of the backbone are affected. And if this happens, there could be collapse of the area with compromise potentially of the spinal cord, and that will constitute an emergency. Other features related to the bony involvement in multiple myeloma are pertaining to high calcium. And these patients can be very symptomatic with confusion, abdominal pain, passing lots of urine, and therefore very thirsty. And that also would be an emergency. Unfortunately, some patients have significantly advanced renal disease by the time they are diagnosed, and some patients become dialysis dependent. For some patients, this is reversible on starting treatment. For others, unfortunately, it is not. And here we can see a biopsy of a kidney. So you see the normal filtering area of the kidney here, but in multiple myeloma, this can become full of some of those monoclonal paraproteins and light chains that I described to you earlier. And that's why patients with multiple myeloma develop renal impairment. The other big implication of multiple myeloma clinically is infection. And this is because we lose our normal polyclonal immunoglobulins, or our memory of our past infections, when we develop multiple myeloma. Unfortunately, a subset of patients with multiple myeloma have very non-specific features, and this can make diagnosis difficult. So here we can see for multiple myeloma that for many patients, up to a fifth, the presenting symptom can be simply tiredness, which is very non-specific. For a majority of patients, the presenting feature can be pain. And again, these are non-specific features that can be difficult for the GP or whatever doctor you present to tease out initially. And for this reason, it's very common actually for the diagnosis of multiple myeloma to be quite delayed. So this is a study that was published in 2012 where they compared the number of visits to the GP required before a diagnosis of a particular cancer is made. And you can see that multiple myeloma proves particularly challenging, with nearly half of patients in some studies requiring up to 3 visits or greater to eventually be diagnosed with multiple myeloma. So now we'll just talk broadly about the management of multiple myeloma. So there are a number of principles to management. One of the first is to address the complications of the disease when the patient presents initially. This could be a patient presenting with a fracture in one of their bones, a compromise of their spinal cord related to disease in their backbone, or it could be a patient requiring dialysis or treatment for renal failure. So often it can present as a medical emergency. We admit the patient and we deal with whatever complications that patient has. The next facet of treatment deals with targeting the multiple myeloma plasma cells that are present in the bone marrow. And this requires treatment with chemotherapy. So depending on your myeloma, your general fitness, your age, a regimen will be tailored for you that will contain 2 or 3 drugs, typically starting out. For patients who are eligible, and generally this would be the younger patients or the patients who don't have other medical problems that might compromise their organ function, we proceed to a transplantation. And this is a hematopoietic stem cell transplantation in which we initially collect your own stem cells that I described on the first slide, your normal stem cells that give rise to all your normal blood cells. We give you a large amount of chemotherapy to try and obliterate everything that's in the bone marrow, but especially those malignant plasma cells. And then we give you back your hematopoietic stem cells like a blood transfusion. And for some patients, that is a very important part of treatment. For some people, they are not deemed eligible for this. However, as Dr. Glavy will describe in her talk later, there are an ever-increasing number of novel agents that overcome the inability to undergo a bone marrow or an autologous stem cell transplant, and that allow patients to live for longer and longer every year. Another very important part of treatment pertains to bone protection. So I've shown you on the slide previous how badly the bones can be affected in multiple myeloma. So after treating the complications of the bony disease, we also aim to prevent any further bony problems arising. Another facet of treatment involves preventing and treating infections. And then, of course, the quality of life of patients is a hugely important factor, and the lifestyle of the patient and what is acceptable to them in terms of trips to the hospital. There are, of course, toxicities related to every treatment that you can have. So we need to tailor them to the individual and make sure that their quality of life is not compromised, because thankfully multiple myeloma patients are now living longer and longer, and it's very important that their quality of life is of a high standard. So in terms of supportive management, so I mentioned we deal with the complications of the disease initially. So this can include pain management, radiotherapy to suitable bony lesions or extramedullary lesions, orthopedic interventions if required to stabilize or prevent fractures, for example, treatment of anemia so that energy improves, treatment of infections if a patient has an active infection, and treatment of kidney failure and calcium levels. And this can be a medical emergency, as I mentioned. It's also very important to deal with the psychological distress caused by a diagnosis of multiple myeloma, because this is, as we know, an ongoing chronic disease that patients are living with for longer and longer, and significant support is required in dealing with this. Another important part of treatment is dealing with the management of side effects of treatment. So common side effects for some of the commonly used therapies for multiple myeloma would include nausea, vomiting and diarrhea. And we would often, or we would always prophylactically prescribe anti-sickness or antiemetics to try and come around this. We do need to monitor the blood counts closely in patients on treatment for multiple myeloma, because each of the treatments has the ability to make your blood counts go low. Skin rashes is common, and neuropathy is a particularly big problem for patients with multiple myeloma, and I'll talk a little more about that in a moment. Another important aspect is clot prevention, and this is particularly important for patients who are on the immunomodulatory drugs, which Dr. Glavy will describe later. So we generally would start these patients on either aspirin, or if you're slightly higher risk, on an injection of heparin to prevent blood clots from occurring. So in terms of peripheral neuropathy, unfortunately, up to 80% of patients with multiple myeloma can experience this either at the start of the disease or more commonly related to therapy. Probably the biggest culprit nowadays is bortezomib or Velcade, which is a drug that we give as a very important part in the armamentarium against multiple myeloma. We have seen an improvement in terms of the amount of patients experiencing neuropathy as we moved from a twice weekly dosing to a once weekly dosing. And more recently, we have switched from using bortezomib or Velcade that's given via a drip to a subcutaneous or an injectional administration. And with this, we have seen a lot less neuropathy. Thalidomide isn't used as commonly now, but it's still a good drug for myeloma. And particularly with higher doses of thalidomide and prolonged use, we can see neuropathy. Other causes of neuropathy in multiple myeloma include the protein itself, which can affect the peripheral nerves, and shingles, which can be an important complication of bortezomib or Velcade treatment. Typically, we'll give patients an antiviral to try and prevent this. Kidney damage too can also contribute to peripheral neuropathy in multiple myeloma patients. The symptoms vary, but tend to be things like pins and needles or kind of a nerve type pain. And most commonly it's the hands or the feet that are affected in multiple myeloma. Patients can often describe numbness or a change in sensation, and at its worst it can cause weakness, tremor and loss of dexterity for patients. So we will always ask patients specifically about symptoms of peripheral neuropathy so that we know on time if they're developing these, and we can try and prevent it getting any worse or improving it. The treatment, first of all, is to try and limit the cause. So, for example, if the cause was related to Velcade administration, we can reduce the dose or stop it depending on how severe the peripheral neuropathy is. Even if we've done that and the patient still has neuropathic pain or this kind of burning nerve type pain, we do have a number of drugs we can use, including antidepressants like amitriptyline, which wouldn't be used at the dose that is typically used for depression, but at a much lower dose, which tends to be effective for this type of pain, or antiepileptics like gabapentin or pregabalin. Others can sometimes use opioid drugs or quinine for cramps. Sometimes we will use local anesthetic injections or patches, and particularly for pain related to having had a previous episode of shingles, this can be quite effective. Complementary therapies may have a role and prove effective for some patients, for example, acupuncture or reflexology, and vitamin supplementation, for example, with the B vitamins or magnesium, is felt to help in some cases too. So other aspects of preventative care then include being mindful of infections and trying to prevent them. So for all our patients, we would recommend that they have the annual influenza vaccine to try and prevent flu. We also would prescribe preventative antiviral medications like Valtrex or valacyclovir and Septrin. The Valtrex in particular is to try and prevent shingles, and as I said, this can be a particular complication of Velcade. The use of preventative antibiotics is somewhat controversial, but there is emerging evidence that this can be effective, particularly in some elderly patients. Apologies. This can come at the cost of potential resistance to organisms or opportunistic infections or developing forms of colitis. So this is not uniformly used, but for particular selected high-risk patients, there may be a role for this. The other very commonly used therapy in multiple myeloma for patients who have lost the normal polyclonal immunoglobulins and are developing multiple bacterial infections as a result is to give them a monthly administration of intravenous immunoglobulin. And this is basically like a transfusion or an infusion of immunoglobulins or antibodies from healthy donors. And the idea is that this restores the antibodies that you have lost as a result of the multiple myeloma diagnosis. The other important facet is to prevent kidney problems. So we try to avoid certain medications in patients with multiple myeloma, and the chief ones here would be non-steroidal anti-inflammatories, things like Nurofen, Diphene. We try to avoid these in our patients and manage their pain with other analgesics. We also try to avoid dehydration, as there is a propensity to dry out the kidneys and make any existing renal damage worse. But probably the most important aspect of supportive management in multiple myeloma is bone protection. So multiple myeloma, even if at diagnosis you don't have fractures or major complications to do with your bone, we know that it causes weakening of the bone at the microscopic level. So in normal health, we have two major types of cells in our bone that control the physiology or the normal working of the bone. And these are osteoblasts, which are cells that reside in the bone, and they constantly make new bone at a continuous rate. On the other hand, the flip side of this, you have osteoclasts, which are these larger cells that can slowly resorb or break down the new bone formation. And in health, we have a nice normal balance between the two. They balance each other out, and you have a nice intact bone. Unfortunately, in multiple myeloma, the plasma cells and other cells in the bone marrow start to secrete growth factors and chemicals called cytokines that have deleterious effects on these cells. In the first instance, they stop the osteoblast from functioning correctly. So you have a reduced function of the osteoblast. And unfortunately, they stimulate the osteoclasts to start resorbing more aggressively in multiple myeloma. And this certainly contributes to all the bony manifestations that I discussed with you. So over the normal course of things, you have these structurally intact bones, but in multiple myeloma, even if you don't have a large punched out lesion, the net balance is that the osteoclasts are resorbing more bone. So you have these tiny little microscopic fractures that can eventually cause collapse of the bone on itself. And particularly in the spine or in the vertebral column, this can cause compromise to the spinal cord. So obviously a big priority for the team looking after you is to prevent these complications from arising. So unfortunately, this is a reality for a lot of patients, and up to half of patients will have had a complication of the bony involvement in multiple myeloma. This can include a fracture in more than a third of patients, hypercalcemia, so a dangerously high level of calcium in the blood, or needing surgery to the bone, or having had a spinal cord compression as a result of a fracture in the backbone. So we aim to prevent these. And the greatest the drug that we have in the armamentarium for the bone protection is the bisphosphonates. So the name you'll probably know this as is Zometa or Zolendronic acid. So these are great drugs that have actually really helped to reduce the amount of patients with multiple myeloma suffering these bony complications. And how they work is that they get absorbed into the bone as part of calcium. They get taken up in the bone, and they manage to get in and around these osteoclasts that resorb the bone. And they sit there, and they are released during bony breakdown, and they inhibit the osteoclasts or the resorbers of the bone that are active in multiple myeloma from doing any further damage. And over time, they can really build up the strength of the bone. So apart from preventing new bony complications from arising, they can also reduce pain. They reduce calcium. If you have a dangerously high calcium, this is one of the best drugs to get it down quickly. They improve bone healing, and they preserve mobility, importantly, in our patients, and particularly in elderly patients. And largely this is done by protecting the vertebral or the spinal cord column. Side effects. So generally these are very well tolerated, and most of our patients will be attending monthly for their Zometa. Some patients can describe fever or flu-like illness, particularly after the infusion. So there can be some nausea, and importantly, bisphosphonates are not very suitable for patients with advanced kidney disease. And this is because they are cleared by the kidney. So if the kidneys are not working well, the bisphosphonates can accumulate, and that causes problems. The big side effect that we worry about is a thing called osteonecrosis of the jaw. And if you've been on bisphosphonate therapy, you'll have been asked to get a dental assessment done prior to this happening. And this is to try and prevent this complication here. So here we have an X-ray where you can see that as a result of the bisphosphonate therapy and underlying damage to the or underlying poor dental health, there is a wearing away of the jaw bone, and the vascular or the blood supply of the jaw bone becomes compromised, and this causes death essentially of that. And you can see here the clinical effects on the side here. So we will always ask patients to have a dental assessment before we give them bisphosphonate, and it's important that we would know if you have any dental work or extractions, etc., coming up, because we always give the bone time to heal after that is done before we would give more bisphosphonate. A happy surprise was that in one of the UK trials in multiple myeloma, it was seen that with Zometa in particular, there appears to be a survival advantage for patients with multiple myeloma. And here, so what they did was they had a clinical trial where they compared an older bisphosphonate with Zometa or Zolendronic acid. And what you can see here in this magnified graph is that the red line is the patients who got Zometa, the blue line is the patients who got the other bisphosphonate. And you can see that, so each one that goes down is a patient, and unfortunately we lose. But you can see that the patients with Zometa had a survival advantage, and that they were doing much better over time. So as well as preventing the bony complications of multiple myeloma, we know that Zometa appears to have an effect against the myeloma itself, which is very welcome, and another reason why we try to keep our patients on it for at least 2 years if we can. So newer options then for myeloma bone disease. So as I mentioned, in patients with significant renal impairment or kidney impairment, bisphosphonates are not necessarily suitable. So we do have another option called denosumab or Xgeva. One of the advantages of this particular drug is that it doesn't have to be given via a drip or through a vein. It can be given as an injection, and that it doesn't affect patients who have kidney damage. It's well established for use in prostate cancer and other cancers. And how it works is it binds to a different target within the bone and inhibits that target. It's actually a monoclonal antibody, and it was approved in 2018 by the FDA. One of the downsides is that, apart from being quite expensive, on withdrawal or discontinuation of denosumab or Xgeva, there can be a rapid loss of the bone, which we don't see with bisphosphonates. So that and other reasons, bisphosphonates remain our first choice of treatment for the bony disease. So to summarise then, multiple myeloma is a disease affecting multiple organs, and it often requires input, particularly at the start of your journey, from multiple specialists, including the renal physicians or nephrologists, the radiation oncologists, orthopedic surgeons, whatever we need to do to stabilise whatever damage the myeloma has caused and get on with your treatment. Each patient is different, and the management of the myeloma needs to be tailored to the patient. And Dr. Glavy will go into this in greater detail in her talk. This includes the choice of upfront chemotherapy for the patient, and whether that patient is going to go on and have an autologous stem cell transplant or be treated with drugs alone. Supportive and preventative care are key, and they have really, myeloma patients have benefited greatly from the advances in this area. They've allowed us to get the maximum benefits of these new treatments, which allow patients to live longer and longer. And they're very important too in maintaining quality of life, particularly the bone strengtheners in preventing more bony complications. So thankfully, patients are living longer than ever with multiple myeloma in 2020. Thank you for your attention, and I'll be happy to take any questions.